Hi, I'm Jeff Cohen of the Florida Healthcare Law Firm in Delray Beach, Florida. I wanted to spend just a few minutes with you and talk with you about healthcare reform and how it might affect physicians. The healthcare reform law essentially accomplishes two things. It's going to flow more insured patients into your offices, number one, through Medicaid expansion and employer mandates and the like. So you're going to have more insureds, more patients. That's the first thing. The second thing is, and more importantly, the cost curve, as it's described by Obama, is going to be reversed or bent. In other words, the cost of healthcare is going to be brought down. The primary method of bringing the cost of healthcare down is changing the payment methodology. Right now we're in a fee-for-service system where what you do, the more you do it, the more expensive the resources are, the more you get paid. Over time, that's expected to change. For example, healthcare savings is going to be a measurement, and it's thought that the savings are going to be shared with physicians. We're looking primarily at a three-stage phase-in, according to most think tankers. In other words, we're not going to jump from a fee-for-service environment straight into a capitation environment where you get a per member per month fee. No, that's what they're saying, is that we're going to be moving into a shared savings environment for a particular time. At some point, you will move into a second stage, according to the Berkeley Center on Health and Economic and Family Security says the second stage is bundled payments or episodic payments or disease state payments. And the third stage, if we get there, is pure capitation, where you're receiving a per member per month fee and you're responsible for delivering the care and managing the money. I think the most important thing for physicians to understand is that the two things that are going to be required to move forward are to be able to manage the money that's received. You're going to need to be able to track it and manage it and improve economic efficiency through whatever means you can, number one. Number two, you're going to need to measure, track, and communicate clinical outcomes. Why? This law not only changes the way that physicians are paid, but also ties payment to demonstrating effectiveness. So you're not just going to get money to deliver care, you're going to have to demonstrate that the money that you received actually produced good clinical outcomes. That's a very broad overview, and there's a lot of details in this law. One of the things to keep in mind about the law is it's a 10-year phase-in. We got two presidential administrations. There's an enormous amount of change going on right now and a lot of discussions and experimentation. That's not going to change. What will change is the specifics of the law. The phase-in dates, the amounts available, for example, for information technology implementation, the so-called High-Tech Act. All those dates and timeframes are likely to change. What is not likely to change, in my opinion, is, number one, the use of information technology in your practice, because it's a way to track economic efficiency and it's a way to demonstrate economic efficiency, as well as to track and demonstrate clinical effectiveness. You're going to need to have that in your practice at some point. There's another talk that I have on EMR, electronic medical records, which gets into a little bit more detail about that. So what's the likelihood? The wind down, diminishment of fee-for-service medicine over some period of time, the implementation of quality measures and financial accountability through the use of information technology, so-called EMR or HIT, health information technology, probably the growth or expansion of a focus on primary care medicine, because accountable care organizations, ACOs, are built around the idea that primary care physicians are in a good position to manage or play an expanded role in managing medical care. Probably a multi-tiered system as well, where as you have an expansion of the insured market, there's going to be also an expansion and a greater demand in what I call the proprietary market. For example, like concierge medicine or VIP medicine practices, or even medical home practices, which are a lot more customer-oriented, if you will. And also, this idea that there's going to be a single ACO that you have to play or pay with is probably unlikely. The environment of multi-ACOs, accountable care organizations, is very likely. All of the government regulators are looking at and favoring competition among those models. And there's a presentation for a few minutes about ACOs in greater detail later on. Thank you very much.